I'll be speaking about non-psychotherapeutic approaches for the treatment of female sexual interest and arousal disorder. At the start of my talk, with regards to arousal disorder in females, I would like to speak about also female sexual interest and arousal disorder. For DSM-5, for you should have at least three of the following for minimum 6 months. If such symptoms persist, then we can put the diagnosis. Lack of interest for sexual activity, and having either no sexual interest at all or very little, not having any sexual thoughts or fantasies, not ability to start any sexual intercourse or not responding to the attempts by the spouse, and during sexual intercourse not having any satisfaction and pleasure, and having no sensation around the genitalia or having very few, and at the same time not having any sexual interest or arousal against any sexual image. Between DSM-4 and 5, there are certain differences. In DSM-4, hypoactive sexual desire disorder and arousal disorders, they actually are classified separately. However, in DSM-5, these two, sexual interest and arousal, included under the same umbrella. At the same time, it can be associated with another sexual, non-sexual disorder, and there should be nothing to do with any other psychotic disorder. After having such a diagnosis for females, and maybe say a couple of words about prevalence. Of course, this disorder in females, it is actually coming from women who are having frequent intercourse. There could be some different levels between the spouses in terms of sexual interest. Very rarely, actually, single females apply us for such a disorder. Between DSM-4 and 5, there are differences in the diagnosis and in classification, but we can speak about around 20 to 30% of a prevalence among females. Besides, after putting the diagnosis, as you would appreciate in a single woman, they do not apply with this problem, and therefore it's actually, once there is any problematic incident, probably there is actually less prevalence. So prevalence rate must be actually more. It is around 11 to 30%. As I told you, once there is any discomfort, there is actually a reduction. I would say in females for the sexual interest and arousal disorder is quite common, but only partial of them, as mentioning that they actually experience a problem. For sexual interest and arousal disorder in females, looking at the etiological factors, it is multifactorial. Among them, there are several different factors, such as depressive or anxiety symptoms of the woman may also affect the sexual functions, or any, for example, problem with the partner, maybe relationship issues, some life stresses, they also may contribute. Besides that, physical health, not being so fit, some hormonal dysfunction is another factor. Besides socio-culturally, there's some norms and expectations and upbringing. They also might affect the sexual function. These are among the etiological factors, but therefore it's not actually possible to speak about one single factor. There's a multifactorial. And by considering this whole, also in treatment, there is the need for a multimodal treatment approach. For this multimodal approach, of course, sexual therapy is a part of it, certain pharmacological therapy, and cognitive behavioral therapy. So we actually need a multimodal approach. I would like to touch upon some of the pharmacological agents because we are speaking about non-psychotherapeutic approach for treatment. And in the animal models, for sexual desire stimulation, testosterone, dopamine, norepinephrine, oxytocin, melanocortin, those inhibiting serotonin, opioids, and endocannabinoids, cannabinoids, and the pharmacological agents tried during treatment is filibanserin, bremelantonide, testosterone plus sildenafil, buspro, and nasal testosterone, this cycloserine, buspron, trazodone. And I would like to say a couple of words about these studies performed. Hypoactive sexual desire. In 2015, by FDA, this is approved, filibanserin, for use in females. Filibanserin is 5-HT1A agonist and the dopamine D4 receptors. This is a weak partial agonist and shows the action as the 5-HT2A antagonist. Woman using 100 milligrams of flibanserin when compared to placebo. In terms of basal satisfying sexual activity, there's an increase, and in sexual activity score also a significant improvement. And when compared to placebo, with regards to sexual dysfunction, there is actually an important reduction. In a similar study, 50 and 100 milligrams flibanserin compared to placebo in another study. Again, 100 milligram use in satisfied sexual activity, there is an increase, including the FSFI scores. Similar results actually in the other studies. You can see the statistical significance from 2013 by Kazatov, use of flibanserin when compared to placebo. There's actually an increase, statistically a significant increase in sexual satisfaction score. And women also asked to log a diary, and looking at the scores in those using filibanserin, we observe a significant improvement. Another combination, testosterone plus sildenafil. For lack of sexual desire in a woman is due to the reduced activity of the brain system sensitive to sexuality, or can be due to the activities increasing this inhibition mechanism. So many pharmacological tests. Phosphodiesterase type 5 inhibitors, just like the males, also in females, these inhibitors are worked on, and in women diagnosed with sexual dysfunction, they do not respond to these drugs. About the efficacy and safety of sildenafil, in the studies that performed, and no significant difference when compared to placebo for treatment of sexual dysfunction in females. And then another study, testosterone plus sildenafil, in making a distinction between these two groups initially, with again emotion, sexual attention observed, and with testosterone, there's an increase in sexual attention, and with the emotions through task, and in the combination therapy, there is an increase in gentle response and the subjective arousal. But there is a reduction with testosterone for emotional troop, and therefore no change in sexual functionality index with this combination. Considering these results, if for low sexual desire, testosterone plus phosphodiesterase can actually be a new treatment for a woman, especially for those associated with not paying attention to sexual cues. Another study, testosterone and buspirone. In between the two groups, the high inhibition group selected, high inhibition and low inhibition groups. In the high inhibition group for testosterone sildenafil, and they looking at the scores. In the high inhibition group, testosterone buspirone combination showed more better gentle and subjective arousal, higher sexual satisfaction, and more powerful sexual improvement. Another study, low sexual attention group treated with testosterone sildenafil, and when compared to placebo, better gentle and subjective arousal and sexual satisfaction again observed. Of course, sample size is small, and at the same time, there is actually not so it's not so easy to make a distinction between those with low and high sexual desire, and therefore there is the need actually for more studies to understand the efficacy and safety of these drugs. Among the other agents, testosterone gel form used and synthetic peptide molecule also tested, besides the combination of the previous studies. Bremelanotide is a melanocortin receptor agonist at the medial preoptic domain, stimulating dopamine release. In a randomized controlled trial for 12 months, the subjects applied subcutaneously bremelanotide 45 minutes before sexual activity, single dose a day, and not more than 16 doses for 4 weeks. In the female sexual function index, we observe increase, but there is mostly redness and itching as a side effect. Testosterone intranasal gel. With the gel, as a response to an erotic movie, they show looking at the effects on the genital and subjective sexual arousal, and worked on the woman with an orgasm. As a result of the study, in hypoactive sexual desire, when gel compared to an intrasa patch, the intranasal gel has more positive effect. Another agent, synthetic peptide molecule. This cyclocerin is an NMDA partial agonist, and we know that it's actually facilitating efficacy. Another agent, bupropion. There is actually no FDA approval yet, but in sexual dysfunction disorders, it's being used and plays a role in treatment of lack of sexual interest, but still not identified with good, well-designed clinical studies, and at the same time, no FDA approval yet. Thank you for your attention.